Some early addiction treatment programs paired the taste or smell of alcohol with a deliberately induced nausea-producing medication, aiming to create a learned aversion strong enough to override an existing craving. This approach, aversion therapy, represents classical conditioning applied directly and deliberately to clinical treatment, though its effectiveness, ethics, and appropriate role remain considerably more contested than gentler conditioning-based alternatives. Aversion therapy applies classical conditioning principles directly to reduce an undesirable behavior by repeatedly pairing the stimulus associated with that behavior, the taste of alcohol, the site of a specific problematic stimulus in some treatment protocols, with a genuinely unpleasant unconditioned stimulus, such as a nausea-inducing medication or, in some older and now largely discontinued protocols, mild electric shock, with the explicit goal of creating a new, learned negative association strong enough to compete with and override the existing positive or neutral association, maintaining the problematic behavior. Disulfiram, marketed as Antabuse, is a medication that blocks a specific enzyme in the body's normal alcohol metabolism pathway, causing an extremely unpleasant, though not typically medically dangerous, buildup of acetaldehyde and resulting severe nausea, flushing, and heart palpitations whenever alcohol is consumed while taking the medication, functioning as a chemically induced form of aversion therapy that provides an immediate, powerfully unpleasant consequence specifically for alcohol consumption, intended to strengthen a patient's motivation and ability to maintain abstinence. Counterconditioning is a broader behavioral technique that involves training an incompatible, more adaptive response to replace an existing, undesirable conditioned response to the same stimulus, based on the principle that two directly incompatible physiological or emotional responses, such as relaxation and anxiety, cannot be fully experienced simultaneously. So strengthening one response to a given stimulus necessarily weakens the competing response to that same stimulus over the course of repeated pairing. Systematic desensitization, developed by Joseph Wolpe, is a widely used counterconditioning-based treatment for phobias and anxiety, involving three components: training in deep muscle relaxation techniques, construction of a graduated hierarchy of feared stimuli ranked from least to most anxiety-provoking, and systematic pairing of relaxation with each hierarchy step, beginning with the least feared item and progressing upward only once relaxation is reliably maintained, gradually replacing the anxious response to each feared stimulus with an incompatible relaxation response through this graduated, systematic pairing process. Systematic reviews comparing aversion therapy to exposure-based counterconditioning approaches, including systematic desensitization, find considerably weaker and more inconsistent long-term evidence supporting aversion therapy's durable effectiveness, particularly outside of pharmacologically supported applications like disulfiram, used within a broader comprehensive treatment program. Since the learned aversion produced by classical conditioning-based aversive pairing alone frequently extinguishes relatively quickly once the aversive consequence is no longer regularly experienced or reinforced, unlike the more durable, adaptive relearning produced by graduated exposure-based methods. Aversion therapy raises significant, well-documented ethical concerns, centering on the genuine distress deliberately induced during treatment, the critical importance of full informed consent given this deliberate discomfort, and a troubling documented history of clinical misuse, most notably the widely condemned and now largely abandoned application of aversion therapy techniques in so-called conversion therapy attempting to change sexual orientation, a practice now recognized as both ethically unacceptable and scientifically unsupported, leading modern clinical ethics guidelines to restrict aversion therapy to narrow, carefully justified applications with robust informed consent and oversight. Aversion therapy and counterconditioning both apply classical conditioning principles directly to clinical treatment, but with markedly different evidence bases, ethical profiles, and appropriate scope of use. Gentler, exposure-based counterconditioning approaches like systematic desensitization generally show stronger, more durable evidence than aversive pairing techniques, which today occupy a considerably narrower and more ethically constrained role in clinical practice.